Hi again, Holly Hood here. Wasn't the Disney princess from this morning amazing? She has an awesome, beautiful voice. We hope you enjoyed it and we hope you had some time to get lunch. Welcome back. This is a pre-recorded session titled Endocrine Issues with Dr. Hale. He has a lot of great information in this session, so we hope that you enjoy it and you get a lot of resources from it. Again, if you have any questions during his presentation, go ahead and type them into the chat box and one of our staff will get with him after the conference is over. Again, please mute yourself and turn off your camera during the presentation. We really appreciate it. We will pop a few more links into the chat, so if you're interested in our silent auction, some Chromosome 18 merchandise, or more information about our Starfish Family Fun Night and table touring event, those will be in the chat box as well. Let's see if I forgot anything. No, I think that is it. Oh, I do have a joke for you. Are you ready? Why is a banana the best fruit? Anybody? Because it has a peel. All right. Well, before we get started with the presentation, I want to share just a little bit more about Dr. Hale. So Dr. Hale is a graduate of the University of Texas Medical School in Dallas and completed his pediatric residency at the Medical University of South Carolina. After completing his pediatric endocrinology fellowship at Children's Hospital of Philadelphia, Dr. Hale served on the faculty at the University of Pennsylvania. He then returned to his native Texas, where he was the division chief of pediatric endocrinology and diabetes at the University of Texas Health Science Center here in San Antonio. While in Texas, he developed the Pediatric Clinical Research Center. Subsequently, he directed numerous clinical research projects and played a significant role in the Chromosome 18 Clinical Research Center. He returned to Pennsylvania to become the Division Chief of Pediatric Endocrinology and Diabetes at Penn State Children's Hospital. Dr. Hale has been an avid supporter of the Chromosome 18 Clinical Research Center for over 20 years. We really appreciate you, Dr. Hale, and everything that you do. And without further ado, we will go ahead and get started with the presentation, Endocrine Issues with Dr. Hale.
Hi, everybody. Many of you know me. I'm sorry we can't be doing this in person. On the other hand, it's nice to have an international audience and be streamed around the various parts of the world. I'm Dan Hale. I'm a pediatric endocrinologist. I've been involved with the Chromosome 18 group for about 30 years. For the last 5 years, I've lived in Hershey, Pennsylvania. But prior to that, I lived in San Antonio. And I've continued to work with the Chromosome 18 group since I've moved to Hershey. So the goal today was to talk a little bit about the endocrine system and endocrine aspects of the Chromosome 18 disorders. Parts of this talk, many of you have heard before. Also, though, I've been a practicing pediatrician for more than 40 years. And one of the most common questions I hear from families of children with chromosome 18 abnormalities is, well, why doesn't my pediatrician know anything about chromosome 18 disorders? And the answer is that we all get very good at doing the things that we do all the time. The average pediatrician's average patient load is somewhere between 2,000 and 5,000 patients. And even for a specialist like myself, the referral base is something about 10 times as large, or something on the order of about 50,000 children. So the prevalence of something that most people in this room know about, Down syndrome, is generally quoted as about 1 in 700. So it's not unusual for the typical pediatrician to have 3 or 5 boys and girls with Downs in their practice. In contrast, the prevalence of the most common of the chromosome 18 disorders, trisomy 18, is only about 1 in 6,000 live births. The other chromosomal abnormalities have a prevalence of 1 in 50,000 to 1 in 600,000. So it's not surprising that the pediatrician doesn't know anything about chromosome 18 disorders, because he's never seen another child with a chromosome 18 disorder. And she might have learned about it perhaps long ago in medical school. To make the pediatrician's job easier, one of the things that we've done is that we provided the treatment guides, which we'll allude to later, but also as a primary advocate for your children, having a notebook of medical records and test results for the provider to review when you first meet them. If you have a positive interaction with them, make positive comments on social media. If you get a request from the office to fill out a post-visit questionnaire, feel free to do so. And lastly, don't forget to stroke the staff. My mother always baked cookies, and whenever she wanted to go into the primary care provider's office when she was getting older, she could always get in within a day because the staff all knew that she would arrive on time, that she would have cookies for them, and she would be most appreciative of their time and efforts. So the objectives, however, of the specific talk is not to talk about physician relations, but really to summarize a little bit of basic clinical endocrinology, to discuss the endocrine systems and review signs and symptoms and some common tests, to provide guidance on how to find more information on endocrine disorders in children with particular chromosome 18 variants, to delineate a few of the remaining issues, of which there are many, and then try to answer some frequently asked questions. A little bit of terminology here. So the hypothalamus is the part of the brain above the pituitary, which provides nerve input into the pituitary and is largely responsible for the pituitary releasing the hormones that the pituitary is responsible for generating. The pituitary is located quite literally in the center of the head. It's often called the master gland of the body. It produces growth hormone directly, and it also produces a number of other hormones that cause the thyroid, the adrenal, and the gonad to function. The thyroid is located on the anterior neck. It produces thyroid hormone. Thyroid hormone is often called the metabolic hormone, as it has numerous effects on a variety of metabolic pathways. The adrenal, you actually have two of them. They're located on top of the kidneys. Its most important product is cortisol, which is the hormone that helps your body adjust to all kinds of physical stress, such as infection or trauma. It also does make hormones related to helping your body hold on to salt, and also produces a group of substances called androgens, which in ladies are responsible for many of the secondary sexual characteristics, such as pubic hair or axillary hair. The gonad, before birth, the gonad plays an important role in the development of the genital system. And in adolescence, obviously, the gonads play a key role in puberty. And lastly, the pancreatic beta cells. These are the cells in the pancreas that make insulin. And classic childhood onset type 1 diabetes is a consequence of destruction of the beta cells by the immune system. So this is just a picture of the location of the pituitary and the hypothalamus and how they're related to each other. And you can see the location in the brain in the graphic on the upper right side of the slide. As I mentioned, the pituitary produces gonadotropins, so those are the hormones that regulate the gonad. They produce growth hormone, which is important in linear growth primarily. They produce prolactin, which is important in milk letdown in lactating moms. Produce ACTH, which regulates the adrenal, and produces thyroid hormone, or thyroid stimulating hormone, which is important in causing the thyroid to function normally. And so those are the issues that we largely are going to talk about today. A couple more definitions. If I say that somebody has primary hypothyroidism, I mean that in basically that the thyroid gland does not work, that the regulation works, but the thyroid gland, for whatever reason, has lost the ability to function. Secondary hypothyroidism would mean that there was some problem with the systems that regulate the thyroid gland. So in the case of secondary hypothyroidism, Largely, you're talking about the pituitary gland that's not sending out the appropriate signal in the appropriate way to make the thyroid gland work. And if we use the word tertiary, we usually mean that one of the higher centers, either the brain or the area above the pituitary called the hypothalamus, is not providing the appropriate signal to the pituitary to do what the pituitary does. So we see this sometimes in children that have had brain tumors and gotten extensive radiation to the hypothalamic area. And as a consequence, their pituitary doesn't work. And secondary to that, the other endocrine organs do not work, and the children have to be on replacement medications. If we talk about an isolated pituitary deficiency, we basically mean that one or a single anterior pituitary hormone is not being produced. If we say multiple pituitary deficiencies, we usually mean that more than one is not being produced. If we say panhypopituitarism, we mean three or more. And while I won't talk much about diabetes insipidus, this is not sugar diabetes, but this is a loss of one of the functions of the posterior part of the pituitary, where the body makes a substance called antidiuretic hormone, which is a hormone that helps your body hold on to water. And it's important to remember that hormones, in order to do their work, have to come up and attach to the surface of the cell or to enter the cell and to turn on or turn off various other biochemical pathways. And the mechanism that is done is called a receptor. And so the hormone has to come up and bind to the receptor, much the way that the key has to fit into the ignition switch in your car in order for the motor to know what to do. There are lots of different ways that you can cause the ignition switch to not work. You can put bubble gum in the lock. You can put some rust in the lock. You can put some super glue in the lock. Lots of different ways to make the ignition switch not work. To date, at least, there has been no evidence in any of the chromosome 18 disorders that there's a primary problem with the hormone receptor. Therefore, a normal response to hormonal treatment has been expected and is what we have seen. So let's go through the systems one by one that we mentioned earlier. So when we talk about thyroid glands, we describe both a functional state and a structural state. So hypothyroidism means an underactive thyroid, or if somebody's on treatment, that the person is not being adequately treated. Hyperthyroidism is an overactive thyroid, or a child or an individual that is being overtreated. I must say, in the age of COVID and mask, one has to be very careful about saying hypo and hyper, because when they get muffled through a mask, sometimes these two are sort of hard to hear. A third word that we often use is euthyroid, and what that basically means is that the thyroid is functioning normally or that the patient is on adequate treatment. Structural changes can occur in the thyroid, and the structure does not give any real hint to the cause, nor does it give any real hint to the functional state. But if we say that the child has a goiter, that simply means that the gland is large all over. And if we say that the thyroid has a nodule, that means that there's a lump or a bump in the thyroid. The primary hormone that the thyroid gland produces is thyroid hormone, which is typically just called T4. Production of thyroid hormone by the thyroid gland is controlled by the pituitary gland. The hormone that is produced by the pituitary gland to cause the thyroid to work is very logically called thyroid stimulating hormone, or TSH. And if somebody has an underactive thyroid, then you would anticipate that the thyroid level itself should be low, and that the pituitary should be working very hard to try to make the thyroid work harder so the TSH would be high. So they're going in opposite directions. In hyperthyroidism, so in exactly the opposite situation, we typically, if the thyroid is functioning independent of the pituitary, then the thyroid level is typically quite high and the TSH is suppressed or undetectable. The most common cause of hypothyroidism or hyperthyroidism is a condition which is called Hashimoto's thyroiditis. Dr. Hashimoto was the first person that described it in the medical literature. It also sometimes is called chronic lymphocytic thyroiditis, and that reflects a description of what it appeared like in the era when we routinely got thyroid biopsies. And it sometimes is also called an autoimmune thyroiditis, reflecting on the fact that the basis of it is that the immune system has developed a small glitch and has begun to attack the thyroid gland rather than attacking a bacteria or a virus. Hashimoto's thyroiditis is certainly the most common cause of both hyper and hyperthyroidism in all ages, although it's about 10 times more common in men and women, in women than in men. It certainly is more common in a number of chromosomal abnormalities, so not just the chromosome 18 abnormalities, but in trisomy 21 or Down syndrome, and Turner syndrome, and in fact, most of the other major chromosomal abnormalities, there's an increased risk of primary hypothyroidism. At diagnosis, however, the person with Hashimoto's thyroiditis may be hypo, hyper, or euthyroid and may or may not have a goiter. There certainly is a trend to become hypothyroid over time, and there are very specific markers in the bloodstream to make this diagnosis. The other common thyroid problem is Graves' disease. This is a condition where the thyroid is functioning autonomously, and as a consequence, it is overproducing thyroid hormone. There may be some inflammation in the muscles behind the eye, which lead to prominent eyes or what's called proptosis. There are markers for this condition as well in the blood, which is called thyroid stimulating immunoglobulin. In this particular condition, we typically treat with a medication that partially blocks the ability of the thyroid to make thyroid hormone. The signs and symptoms of hypo and hyperthyroidism are shown here, and I'm not going to go through each one of them, but largely the signs and symptoms are hypothyroidism are often quite similar to those of aging, or if those of you have been hanging out with grandparents or great-grandparents lately, they're cold a lot. They often are having issues with hair loss, having issues with dry skin, having issues with depression, having issues with constipation, and just feeling very sluggish and fatigued and perhaps mildly depressed. In contrast, hyperthyroidism is the opposite, so much more like a person that's on a amphetamine, such as what's commonly called speed, or some of the stimulant ADH medications, whereby the person has difficulty with focus and attention. The patient may often be eating a lot and losing weight. They often complain about a racing heart or what's called palpitations. And they may be losing weight despite eating a lot. The prevalence of thyroid disorders is normally quoted as 1 to 3% in the general population. As noted, it becomes more common with increasing age. The most common is Hashimoto's, and the secondary forms are relatively rare. Thyroid disorders are more common in most major chromosomal abnormalities, with a prevalence about 10 times more than that in the general population. Certainly are more common in children with chromosome 18 abnormalities. And in the treatment guidelines, we actually give what we think is the actual prevalence for the different chromosome 18 conditions. Certainly can have early onset in children with chromosome 18 issues. The most common is Hashimoto's thyroiditis, and the secondary forms are rare. Our recommendations in terms of thyroid screening is that all states in the U.S. have newborn screening. So if a child is born in a hospital, almost assuredly they will be screened in the newborn period. The sort of standard testing has been only if the patient develops symptoms. However, we would recommend, because it seems to be considerably more common in individuals with chromosome 18 abnormalities, and also because the pediatricians are accustomed to doing this already for children with Down syndrome, we're currently recommending that thyroid testing just for a free T4 and a TSH be done annually or every other year. And if the child shows evidence of hypothyroidism or has a goiter, consider also measuring the specific antibodies. Treatment plan is straightforward. Standard starting dose is 1 to 2 micrograms per kilogram per day. Normally, once a child is on thyroid hormone, labs are retested again in 4 to 6 weeks. The frequency of testing somewhat dependent on the age of the child, but generally for children between the ages of 3 and 18, recommend testing about every 6 months once the children are actually on thyroid medication. A few other comments related to hypo and hyperthyroidism. The isolated forms of secondary or tertiary hypothyroidism are very rare in all people. They are much more likely to be associated with multiple pituitary defects involving other pituitary hormones. And also, when this is the case, much more likely that the child will have other midline abnormalities such as cleft lip, cleft palate, etc. The medicines that are used to treat hypothyroidism are chemically identical to what the body makes. I always think of this as just putting gas in the gas tank. It certainly is possible to overtreat or undertreat, but there are really no side effects of the medication. And because it is biologically identical to what the normal human thyroid gland makes, you really don't have to worry about interactions of thyroid hormone with other medications. A pill form is primarily used. It's easy to dissolve and no bad taste, but there now is a liquid form that's become available in recent years and certainly is more convenient if children are being tube fed or children have difficulty even with crushed and dissolved medications. A little bit vocabulary related to the adrenal. Adrenal insufficiency is normally called Addison's disease or primary adrenal insufficiency. Excess is often called either Cushing's disease or Cushing's syndrome. The adrenal, as we mentioned earlier, produces 3 important substances: cortisol, which is the stress hormone; aldosterone, which is a hormone that helps your body hold on to salt; and androgens, which are often referred to as male hormones. Adrenal cortisol production is regulated by the pituitary gland through the production of adrenocorticotropic hormone, or ACTH. The most common reason for adrenal steroid excess is the prolonged use of high doses of glucocorticoids to treat inflammatory conditions such as severe asthma, lupus, or rheumatoid arthritis. The most common reason for adrenal steroid insufficiency is after the patient has been on high-dose steroids for long periods of time. This can cause the adrenal gland to atrophy, and therefore when the medication stops, the patient becomes adrenally insufficient. There are certainly rare conditions that can cause the adrenal or the pituitary to malfunction, which I'm not going to address today. Classic signs and symptoms of adrenal insufficiency, so Addison's disease, can be changes in the pigment of the skin. Individuals, cortisol helps maintain blood sugar, so issues with hypoglycemia, issues with hypotension, low blood pressure. People often have substantial malaise or fatigue. They don't feel well. In contrast, Cushing's syndrome is often associated with rapid weight gain, increased obesity of the trunk, issues with fluid retention. And if any of the adults in the room had a friend or a relative who had to be on high-dose steroids to treat their lupus or their rheumatoid arthritis or some other inflammatory process, they basically had a physician-caused or medication-caused Cushing's syndrome. Adrenal insufficiency, not secondary to a medical treatment or trauma, is quite rare in the general population, generally quoted as 4 to 8 new cases per year per million people. Tends to be more common in females than males, more common in adults than children. There are some very rare familial or genetic forms. Adrenal steroid excess, not secondary to medical treatment, is also extremely rare in the general population, about 0.2 to 0.5 new cases per year per million people. Again, more common in women, more common in adults than children, and there are, again, very rare familial or genetic forms. With specific reference to children with chromosome 18 abnormalities, there is neither insufficiency or excess or known to have an increased prevalence in children with other chromosomal abnormalities. There doesn't seem to be any increased prevalence in children with chromosome 18 abnormalities. On the other hand, there's nothing about chromosome 18 abnormalities that puts individuals at decreased risk for either Addison's or Cushing's. It is worth noting that the ones that one would be most suspicious about the possibility of this would be individuals with midline defects or significant structural abnormalities of the central nervous system, or in children that have other pituitary deficiencies. And then those children would be at increased risk of secondary or tertiary adrenal insufficiency. The recommendations for the children with chromosome 18 abnormalities is no routine testing unless the child has other secondary endocrine dysfunction, such as growth hormone deficiency, hypoglycemia, an unanticipated reaction to surgery, anesthesia, or illness, or if the child has been exposed to high-dose steroids for prolonged periods of time. Replacement doses, if and when they're needed, are similar to those in children that don't have an underlying chromosomal disorder. The stress doses also tend to be similar to what we done in typical children who had adrenal insufficiency. So the recommendations are no routine testing. If there is considerable suspicion, it's probably the appropriate time to ask for a referral to an endocrinologist. Some children with chromosome 18 abnormalities have adrenal insufficiency. These tend to be children with other pituitary deficiencies or children that have had prolonged exposure to steroids for other reasons, which is, as I noted, cortisol levels, by the way, are often measured as part of the growth hormone-related testing that is done. I am not aware of any cases of adrenal corticoid excess in children with chromosome 18 abnormalities. So we should move on to gonadotropins then. So gonadotropins are those hormones that regulate the testis in the male and the ovary in the female. Anytime you see trophic or trophin on the end of a medical word, that just means something that stimulates growth or function. Gonadotropins are one of two hormones from the pituitary that stimulate gonad function. Luteinizing hormone is responsible for stimulating ovulation in ladies and testosterone production in males. Follicle stimulating hormone stimulates the ovarian follicle before ovulation, and in the male, it stimulates sperm production. If we use the word precocious puberty, and we'll get to that in a minute, it's defined as evidence of puberty before age 8 in a female or before age 9 in a male. And delayed puberty is no evidence of puberty by age 14 in the female or age 15 in the male, although certainly we often will see people at earlier ages when there are these concerns. In infants, a lack of the gonadotropins can be associated with genital abnormalities in male infants, such as an undescended testis, an underdeveloped penis. There are no obvious findings in females that are born with gonadotropin deficiency. In children, gonadotropin deficiencies can be associated with both gonadotropin abnormalities can be associated with both precocious and delayed puberty. And in adults, issues with gonadotropins can affect the menstrual cycle in females or be associated with fertility issues in either males or females. The genital abnormalities in typical male infants, hypospadias, which is where the opening out of the penis is at the base or along the shaft of the penis as opposed to on the tip, is about 1 in 200 infants. An undescended testis is about 3 in 100. Bilateral undescended testis is about 3 in 1,000. And this is term infants, a bit higher in preterm infants. External genital abnormalities are uncommon in female infants. Precocious puberty, generally quoted as 0.3 to 3 per 100 girls, and about 0.3 to about 0.6 per 1,000. I'm sorry, 0.3 to 6 per 1,000 for the boys. So about 10 times less common in boys than in girls. More common in overweight girls than girls of average weight or thin. Pubertal delay, about 0.5 to 1 per 100 in girls, about 1 to 2 per 100 in boys. It's certainly more common in underweight children and those with a family history of pubertal delay. In chromosome 18, suggestions of gonadotropin abnormalities vary a bit by condition, and those are broken out in the treatment guidelines. For example, almost 50% of the boys with 18q have a genital abnormality, either an undescended testis or hypospadias. There are case reports of precocious puberty and all of the chromosome 18 conditions, but there is no information on the prevalence of that, but there are case reports. There are also case reports of delayed puberty in all the chromosome 18 conditions as well. This might in part be related to nutritional status. In the chromosome 18 abnormalities, the average age of onset of menses in girls with 18q is only delayed by about 1 year. Menstrual issues are quite common, but no data to suggest that it's more common than that seen in the general population. We know that fertility is also possible in females with some conditions, such as 18q and 18p, and unknown in others. Fertility on the male side of things, we know that that we have at least a couple of patients who don't make sperm. So there are case reports of 18q. We don't have a wealth of data on the boys in terms of their fertility for the other abnormalities. So recommendations have been that an approach to these issues for children who have chromosome 18 abnormalities should be exactly the same as it is for children who don't have chromosome 18 conditions. Surgical corrections are available for certain infant genital anomalies. For example, when the children have a hypospadias to move the urethral meatus out onto the head of the phallus. The children seem to have a normal toleration for surgical procedures. They appear to have good cosmetic outcomes. And while we don't have a wealth of information, the children seem to have normal function in terms of, for boys, the ability to stand up, to urinate, to have normal testosterone levels and normal sexual interest and sexual function. There are medications available with outcomes as anticipated and no unique aspects to chromosome 18, as far as we know, to stop puberty if it occurs early, to start puberty if there's significant delay, or to regulate menstrual cycle if there are problems. And so we will now transition on to talk a bit about growth hormone. Growth hormone is the most important growth promoting hormone after 1 year of age. Prior to 1 year of age, insulin and thyroid hormone play very important roles as well. IGF-1 is a growth factor that's produced by the liver and growing bone in response to growth hormone. And it is, in fact, the IGF-1 which is typically used as a screening test for growth hormone deficiency because it involves a single blood draw. There's another growth factor that is similarly used called insulin-like growth factor binding protein 3. Growth hormone is produced in a pulsatile fashion with most production occurring while sleeping. The definitive test for growth hormone is called a growth hormone provocative test or a growth hormone stimulation test. 2 tests are typically done, which may be done on the same day or different days dependent on local protocol. Each test takes 1.5 to 2 hours and involves multiple blood draws. And the purpose of the test is really to try to reproduce a growth hormone pulse, such as should normally occur, normally when the person is sleeping. So if somebody says they have been tested for growth hormone, if it's a single blood draw, chances are they have the growth factors obtained. If they said it was a 3-hour test or a 4-hour test with multiple blood tests, then almost assuredly you had growth hormone stimulation testing done. Linear growth in the first year of life is primarily dependent on insulin, and insulin is primarily dependent on adequate weight gain and adequate caloric intake, and that in turn requires adequate nutrition, not growth hormone. The expected rate of linear growth and weight gain for genetically unremarkable children of all ages are well delineated and widely available. It is my opinion that there should not be different standards for children with chromosome 18 conditions, and that the children should be followed in the same way that children that are genetically unremarkable are followed. And if the children begin to lag behind by either weight or height, they should be dealt with aggressively. Rates of growth vary dramatically across childhood and are different for boys and girls, but there are growth velocity charts that every pediatrician has, but also are easily findable on the internet, where you can literally say how fast should a 5-year-old be growing, or how fast should a 10-year-old be growing. Growth hormone, or the lack thereof, affects your growth rate. And growth rate, by definition, has to be slower than normal for a child to get behind or to be actually short. Here's what a velocity chart looks like. If you haven't seen these before or don't know what you're looking for on the internet, um, simply shows along the x-axis is shown the age of the child, and on the y-axis is shown the growth velocity, so the rate over an interval period of time, annualized. And I would get you to focus on the left-hand slide and look at the solid red line. That is the typical rate of the 50th percentile rate of growth for children between the ages of 2 up until about boys, 2 up till about 17. And you can appreciate that most of childhood growth slows down up until the point that puberty starts, in which case the children get their growth acceleration, and then slowing down until such time as typical boys stop growing around 17. The two dashed lines are for those boys that are early developers, and those are boys for late developers. And remember earlier that I mentioned to you that rate of growth is very age dependent. So the answer here is, let's take this person right here who's a boy at 13 and a half. You can appreciate that if he is already towards the end of puberty, his growth rate's right on the 50th percentile. If he's just starting puberty, he's right on the 50th percentile. But if he's right in the middle of puberty with this kind of growth rate, his growth rate is about half of what it should be. Just important to look at rate of growth and not just how tall the child is. Growth hormone deficiency in the general population is generally quoted as about 1 in 2,000 in typical children. It is more common in a number of other chromosomal abnormalities, such as a condition called Prader-Willi syndrome. It may occur in the context of multiple pituitary disorders or alone. It's more common in children with midline defects, such as cleft lip, cleft palate, spina bifida. And it's more common in children that have had any negative thing happen to their head or brain. It also is more common in children with chromosome 18 abnormalities. The treatment guidelines give the actual prevalence for the different chromosome 18 conditions, ranging between about 15 up to more than, or to about 60%. So my opinion with reference to the chromosome 18 children is to have a higher index of suspicion generally, since a prevalence of 15 out of 100 is dramatically different than a prevalence of 1 in 2,000. And there should be an even higher index of suspicion if the child has other pituitary defects, has midline defects, or had an adverse event. Recommendations, and this is true, I think, for all children and in dealing with all providers, look at the child, not at the laboratory test. And it's always a good idea to say something along the lines of, if my child was not genetically remarkable, what would be your evaluation of his or her poor growth? And once you hear that explanation, then say, so can we just proceed down that path for now? That often gets around the arguments of rights and wrongs, but simply makes the point that the expectation is that a child with a chromosome 18 should be treated as a child who is not genetically so remarkable. Pharmacologically, growth hormone is biologically identical to what the human pituitary makes. It's safe and effective. The major downside, it is injection that's administered at home, and children on growth hormone are typically followed by an endocrinologist every 3 to 6 weeks. However, growth hormone does not work well if the child is not gaining weight. So here are some specific, frequently asked questions about growth hormone. Will my child's growth improve on growth hormone? The answer is most growth hormone deficient children respond well to growth hormone treatment. typically showing a significant increase in rate of linear growth within 6 months of starting treatment. Are there side effects to be watched for? The pediatric endocrinologist will go over things to watch for. There are a few problems that happen during periods of rapid growth that appear to be a bit more common on growth hormone treatment, but there does not seem to be any increased risk of these things happening in children with chromosome 18 abnormalities over the general population of children on growth hormone. Does growth hormone cause cancer? There's no evidence that growth hormone causes cancer in typical growth hormone deficient children. There is no data specific to chromosome 18 children, but there's no reason to think that children with chromosome 18 abnormalities are at increased risk. Because the growth hormone given as medication is identical to what the normal human pituitary makes, it's hard to imagine how administered growth hormone would increase a child's risk of cancer. Does growth hormone have other benefits for a child other than growth? So we have to be cautious here. There are no objectively proven benefits other than growth and changes in body composition in typical children who are growth hormone deficient. It's widely believed that there are a variety of other benefits, including improved wound healing, enhanced stamina, improved immunity, less depression, improved muscle function, improved cardiovascular function, etc. But these have never been extensively studied or proven in an objective sense. Does growth hormone have other benefits for a child other than growth in special populations? Benefits certainly similar to those in typical growth hormone deficient children on growth hormone treatment have been reported in children with a wide variety of other conditions. The only two that have been objectively demonstrated, documented, peer reviewed, and published are neurocognition and body composition and Prader-Willi syndrome, and neurocognition in 18q deletion children who are growth hormone deficient. What is known about any benefits of growth hormone on children with chromosome 18 conditions other than those already mentioned? So the answer is that's a question we would really love to answer more fully. There is nothing in terms of peer-reviewed publications. We did a small project that showed that short and slowly growing children with 18q deletion that didn't meet classical criteria for growth hormone deficiency clearly had improved growth on growth hormone treatment. And that we know that the growth response to growth hormone in children with the other chromosome 18 conditions that are growth hormone deficient appear to be similar to that of typical children with growth hormone deficiency. My young adult has growth hormone deficiency as a child. Is there any need for growth hormone treatment as an adult? Possibly. Typical individuals produce growth hormone as adult. Growth hormone in adults plays a maintenance function for maintaining lean body mass and cardiovascular health. In adults with a history of childhood growth hormone deficiency are retested as adults. There fall in two categories. There are those who are no longer deficient, and there are those that are still deficient. And for those that are still deficient, the ones that one would think about treating are those who are symptomatic. Why is it so difficult to get a child or an adult on growth hormone? So the major factor, quite honestly, is cost. For a 20-kilo child, you're talking about a year of college, or about $31,000 a year, and the price goes up proportionally to the body's weight. So compared to state colleges, maybe that's 2 years of college, to private tuition, that's probably 1 or less than 1 year of college. So it's expensive, and that has been the historical concern about its use. What is required to get growth hormone approved? For most children, a height of less than the 5th percentile for age and sex, the bone age, which is a marker for skeletal maturation, to be delayed. The child has to be growing slowly for their age, and they have to have failed to pass two growth hormone stimulation tests. There are some special circumstances that on occasion, that we use all the time, and may be useful in trying to get growth hormone for a child with a chromosome 18 abnormality. If the child is small for gestational age, that often is and has not caught up by age 2, that is alone an indication. There are certain specific known genetic conditions, such as Turner syndrome or Prader-Willi syndrome, where it's improved indication, or if the child has multiple pituitary deficiencies. For adults, there are very specific standards that are used to make that assessment. For all children on growth hormone, extensive documentation of their growth, their weight, extensive paperwork, and annual renewals. And to wrap up, there certainly are some online resources for you for endocrine issues. The hormone.org website is maintained by the Endocrine Society and the Pediatric Endocrine Society. It's a very reliable source of information on the hormones, not necessarily on all the conditions, but on the hormones and the various their various use in treatment. The Human Growth Foundation also has information available on growth hormone. For example, it is not targeted towards the chromosome 18 abnormalities. And of course, the Chromosome 18 Registry and Research Society maintains the most recent information specific to chromosome 18 on both the Chromosome 18 Research Center and on the webpage, and on the Chromosome 18 Registry and Research Society web pages as well. So with that, I thank you for your attention. I hope this has been helpful to you. I hope I haven't bored too many of you too much. And I appreciate your time in listening to me. And as always, if questions, please send them to Annis, and she will take it from there. Thank you very much.